So hello, and thank you for joining the webinar today, The Impact of the COVID-19 Pandemic on Immunization Services, Results from a Survey of Physicians in Ontario. My name is Antonella Pucci. I'm the Project Officer for CANVax at the Canadian Public Health Association, and I'll be the moderator for today's webinar. It's our pleasure to be collaborating with Immunize Canada again to host another 4-part webinar series on the topic of immunizations during the SARS-CoV-2 pandemic. To learn more about our upcoming webinars, please visit our website at canvax.ca/joint Immunize Canada and CANVax Webinar Series, as indicated in the link you see on the screen. Before we begin, we want to acknowledge that the offices of Immunize Canada and CANVax, which are located at the Canadian Public Health Association, are situated on the ancestral and unceded territory of the Algonquin Anishinaabe people. They have been the guardians of this land for millennia, and we are grateful for the example their stewardship provides. Immunize Canada, CANVax, and CPHA are committed to working with all First Nations, Inuit, and Métis peoples and their governments in realizing meaningful truth and reconciliation. As for a bit of housekeeping, it should be noted that all attendees are muted. For this webinar, the Q&A feature located on your toolbar will be used to ask questions. If you have any questions, please type them in the Q&A box, and you can do that at any point during this webinar. Only you, myself, and the presenter can see your questions, but once the question is addressed and the presenter is answering it, everybody will be able to see the question in the All Questions section. If you have any questions regarding technical difficulties, please contact CANVax at cpha.ca and we'll reply to you as soon as we can. If multiple people are experiencing the same problem, we'll also address it live. Finally, just for some quick notes, the webinar is being recorded and will be made available on Immunize Canada's YouTube page, as well as on CANVax a few days after the end of this presentation. Slides will also be available to attendees as well in a post-webinar email, as well as on canvax.ca. And finally, we invite you to take a short 5-minute survey at the end of the webinar to tell us your feedback on the delivery of this webinar. So with that, let's begin. I would like to introduce the speaker for today's webinar, Dr. Pierre-Philippe Piché-Renaud. Dr. Piché-Renaud has completed his pediatric training at the CHU Saint-Justin in Montreal and is now finishing his 2nd year of subspecialty training in pediatric infectious diseases at the Hospital for Sick Children. Throughout his fellowship, he has been involved in Sick Kids' COVID-19 pandemic response plan and has been studying the impact of the pandemic on routine childhood immunization in Ontario and strategies to mitigate any decrease in vaccination coverage. So with that, I would like to turn it over to Dr. Piché-Renaud. Whenever you're ready, you can start sharing your slides.
Thank you very much, Antonella, and thank you to everyone who's joining the webinar today. I'll just share my slides just here. There you go. So hopefully everyone is able to see that. So as Antonella mentioned, I'm just finishing my fellowship in pediatric infectious diseases, and with our division of infectious diseases at Sick Kids, we've been looking into this question of what's happening with the pandemic and what is the impact of the pandemic on the coverage of other vaccines and what could be the impacts on other infectious diseases. So here are my disclosures. Just of note, one of our projects has actually been funded by a competitive grant program that has been posted by Pfizer, but this is investigator-led, and Pfizer is not involved in the design of this study. So for the plan, as introduction, we'll just put the situation of Ontario and Canada into a global perspective and look at the impact of the pandemic on vaccine coverage worldwide. We'll dig into the main topic of the day, which is the result of a survey study that we have conducted within the early phases of the pandemic. We'll talk a little bit of what's happening about the vaccine, around the vaccine coverage in Ontario, and we'll discuss possible solutions to the issues that we will identify. So the impact from the virus in itself is well known on children, and obviously as the Division of Infectious Diseases, we've done quite a bit of work in looking into this impact, the direct impact of the virus in itself on children. And we have led a systematic review to kind of try to assess what is the mortality caused by the virus in itself. And as of December 2020, we have found that there has been 3,788 pediatric deaths worldwide attributed to SARS-CoV-2, and there's been a little bit more than 3,000 ICU admissions. So certainly there's a burden of the infection in itself. But we're thinking that the burden of the indirect impact of the virus is quite high and is probably even higher than the virus in itself, since the virus, as we know, seems to be targeting and has a higher mortality burden in older individuals and individuals with comorbidities. But assessing the indirect impact of the virus is quite elusive, and it's difficult to obtain and quantify, very objective data. So there has been quite many studies that have been trying to look at that question. And even early within the pandemic, there was this modeling study that has been published in Lancet Global Health. So this was in May 2020, so more than a year ago. And what they tried to model is what would be the burden of disease, what would be the burden of death from the indirect impact of the virus, so from the lockdowns. And they estimated that with a strict and prolonged lockdowns, which has certainly been seen now that we are within more than a year of the pandemic, what they have assessed is that secondary to the impact of vaccines, there would be an overburden of 16,000 deaths secondary to disruption into vaccination coverage worldwide. So certainly we can imagine and we can appreciate that specifically with declines of vaccine coverage, the burden of death seems to be even higher than the virus in itself. And this is only for vaccines and not estimations around the impact on other child services. So there's been many studies, trying to advocate for continuation of immunization services worldwide, especially in the context of low and middle income countries. Unfortunately, this is not what has been seen, and this is data from the World Health Organization in assessing what has been the burden of the pandemic on immunization campaigns. And what has been seen is that many countries have reported in the first few months following the pandemic that there has been a complete disruption of their immunization campaigns for one or more vaccines. And very recently, there's been data published on what has been the impact on coverage in the past year and a half. And this has been released by WHO not even 2 weeks ago, essentially. And their data from 2020 has revealed that there has been more than 20 million children that missed out on routine childhood immunization. And this is also shown in this Lancet paper that was also published about 2 weeks ago in trying to show and model what is the data for vaccination coverage worldwide and for various regions. We can see that the burden was certainly higher in the early phases of the pandemic, with some recovery that has followed, but there is quite a big confidence interval, and it is still possible that there is ongoing impact on vaccination programs. And their conclusion is that in 2020, 8.5 million children have not been vaccinated with didnt vaccine, and almost 9 million children were not vaccinated with the measles vaccines, secondary to the pandemic itself. So this is the map from which country they were able to gather their data. As you can see, there is no data that they could gather from Canada. And this speaks to the fact that there are challenges to gather data in Canada because of the provincial nature of healthcare systems, because of different vaccine calendars in each province, because the identification of unimmunized and under-immunized individuals is not simple because of the lack of a centralized electronic and universal registry. And there's no kind of fully integrated systems throughout the country. So this requires data triangulation, and looking into vaccine coverage with precise data is quite challenging. So data on the impact of COVID-19 on immunizations in Canada is actually quite scarce compared to what is available in the global health literature of such an impact. So we have tried to kind of fill in this gap by leading multiple studies to, first of all, try to objectify what is the impact of the pandemic on routine childhood immunization, and secondary to that, if there is an impact, could we try to identify some solutions into mitigating this impact. So just before we go into the results from the study in itself, just to review the immunization calendar here in Ontario, just to kind of understand who is giving vaccines here in the province. The primary immunization series and the boosters that are given at 18 months are actually given by healthcare providers. So mostly family physicians and pediatricians. Some nurses may give these vaccines in clinics in association with physicians, but most of them will be given by physicians. Pharmacists can give vaccine to children as well, but only if they are more than 5 years old. So this is the regulation here in Ontario. And the vaccines that are given in grade 7, the vaccines that you can see here, so hepatitis B, the quadrivalent meningococcal vaccine, and HPV, are a responsibility of public health, which give these vaccines usually in school-based settings. So we decided to target physicians and trying to ask them if there was any impact on their immunization services at all, and if there was this impact, what was it exactly? So what we have done is that we have partnered with the Pediatricians Alliance of Ontario and the Department of Family and Community Medicine at the University of Toronto, and we have designed a cross-sectional study that has been administered online and was taken by participants from listserv from these two institutions, which include 1,300 pediatricians and almost 2,000 family physicians throughout Ontario. Of note, the family physicians that have been surveyed were mostly scattered through the Greater Toronto area. So the survey had 3 sections. The first one was to identify what were provider social, demographic, and practice characteristics. The second one was the impact of COVID-19 on clinical practice, mostly on the rate of in-person versus virtual visit. And lastly, obviously, the impact of the pandemic on immunization services. And we have included open-ended questions about possible solutions that practitioners could identify or have been implementing in their settings. So we have received 475 answers, 286 from pediatricians and 189 from family physicians. This corresponds to a total response rates of about 20%. The survey was available actually just a year ago, so from May 27 to July 5. Here we have the characteristics of the respondents. So of interest, we can see that most physicians who have answered were a bit later in their practice, with about 12% who were less than 5 years old into practice. The setting of practices were mostly in urban and suburban setting, with few percentage answering from rural or remote settings. Most physicians obviously reported providing vaccine on a regular basis to children. Some pediatricians or some family physicians answered the survey to provide input about possible solutions that they could think about. But some of these physicians, like a small percentage, reported not giving vaccines on a regular basis. So this is the distribution of our survey respondents throughout the province. So you can see that it's pretty well distributed, but certainly there is an area of focus here in the Greater Toronto area, around Hamilton and around Ottawa as well. So mostly in urban settings. So in total, respondents have mentioned that there was an impact of the COVID-19 pandemic on their immunization services in 45%. So 175 mentioned that, yes, the pandemic had an impact on their immunization practices, whereas 270, which is about 55%, mentioned that they continued their immunization services similarly to what they've been doing before the pandemic. These percentages are calculated based on the number of respondents who have acknowledged giving vaccines on a regular basis. So this is the disaggregated results of what was the impact exactly. So a very small percentage actually mentioned that there was a complete disruption of their immunization practices in that stage of the pandemic, with 5% mentioning that their practice was completely closed at that time. 1% mentioned that all vaccines were postponed. 1% mentioned that they just told their patients to get vaccinated elsewhere. And the majority actually mentioned that the impact that they noticed was that they gave vaccines only to a specific age range of children, and we'll get into some of the detail around what ages they continue to give vaccines. A minority of respondents have mentioned that they gave vaccines to only high-risk group of children that they have identified. So unsurprisingly, from the respondents who have mentioned that they continued vaccines only in specific group of patients, most of them have continued them for patients who were aged 18 months and less. So the primary series with the booster at 18 months, and the majority of participants mentioned that the impact was seen in the 4 to 6 years old age range. So for the booster dose that is supposed to be given at that age. So this is the main impact that they have been noticed. And then here you can see that a very small percentage would give vaccines to teenager and grade 7 children. But as we saw from the Ontario immunization schedule, these vaccines are usually given in school settings. But we'll get back to this point in just a moment. So these results were kind of unsurprising because they were aligned with guidance that was posted by NASI in May of 2020, so around the time that we were doing the survey. So what they recommended is that physicians should prioritize the primary immunization series, so for children 18 months and younger, and that boosters that is given between 4 to 6 can be deferred, but it should be prioritized for patients who have missed immunization doses before. And then what was recommended then is school-based immunizations to be given when schools reopen. But as we know, now that we have a year and a half of look back, this has been an ongoing issue. And as I mentioned, we'll go into more details around that shortly. So this is certainly partly explained by the fact that respondents have acknowledged that there was an important reduction in the proportion of in-person visits. So you can see here that pediatrician, the median of in-person visit that they saw before the pandemic was 100%, and after the pandemic, or during the pandemic rather, the median of in-person visit dropped to 25%. And this has been even more important for family physician, reported 95.5% of their visits were in person before the pandemic, and during the pandemic it dropped down to 12.0%. We have also identified what were predictors of modification of immunization practices with a composite score that included all the possible modification of immunization practices, including complete closure of the practice, including specifically giving vaccines to some age group. And what we have identified from our survey is that pediatricians seem to be at higher risk of this modification, interestingly, compared to family physician in our multivariate analysis with the multivariate logistic regression that we have performed. Physicians who were less than 5 years into practice seem to be at higher risk of modifying, seem to be actually associated with higher modification of their immunization practices, as we can see here. Unfortunately, with the design of our survey, we can't really know the reasons for these findings, but it is possible that it is because physicians with more experience have seen some of these vaccine-preventable diseases and therefore may be inclined to continue their immunization services compared to younger physicians. Or it's also possible that younger physicians were redirected to give COVID-19 related care in other settings. Lastly, we can see here that physicians practicing in a urban setting were more impacted than physicians who have been practicing in a suburban setting, which ties into like the epidemiology of SARS-CoV-2, since there were higher transmission rates in urban settings as well. We have also assessed some of the other impacts of the pandemic. So this finding is quite interesting, actually, because we found that actually 30% of our survey respondents, so 118, have reported that they were providing immunizations to patients from other clinics that were sent to their own clinic. So this speaks to the fact that we may have not captured, or we may have underestimated the burden of the impact of the pandemic through this survey, because certainly there is some selection bias, and people who have responded to the survey may be more inclined or more find that immunization services are more important than people who did not answer the survey. And this finding actually speaks to that, in that people who have completely closed their practice or have redirected their patients to other clinics are probably less likely to have responded to our survey than people who actually saw these patients. One of the concerning findings that we have found in our survey is that the majority of respondents, so more than 50%, reported that they lacked a system in place to keep track of the patients who may have missed vaccine doses. So this speaks to what I have discussed previously, and that there is no universal electronic registry of immunizations. Hence, it is quite challenging in Ontario to keep track of which children could have missed on immunizations. And this certainly will be challenging in planning the catch-up schedules for children and the catch-up strategies that should actually be implemented. Barriers that have been identified by respondents were multiple. This is from a multiple choice question. So we have had identified these barriers previously, but certainly the main barrier that respondents have acknowledged is the fact that parents were concerned about the risk of contracting COVID-19 in healthcare settings by far, as you can see here. So almost 80% of our respondents acknowledge this as a barrier to their immunization services. A little bit less frequently, but very closely to this result actually, were the staff being concerned about the risk of contracting COVID-19, leading to decrease in their availabilities for children to get vaccines, and the lack of PPE in their practice to safely give vaccines. And a small proportion actually identify a lack of medical staff due to redeployment, illness, or self-isolation. And actually almost 10% identified vaccine shortages or issue in the supply chain as a significant barrier, which I think there's been a bit more awareness now that we are in the distribution of COVID-19 vaccines. We also have asked an open-ended question around what other barriers they could think about. And very interestingly, the comments that have been reported mention school closures as one of the main barriers that they identified to vaccination coverage in general. Other barriers that were identified through this question kind of like tied in with the multiple choice question. But the school closure one was certainly interesting. So we did ask respondents how they would manage their patients who didn't miss vaccination because of school closures. And we need to bear in mind that this was done in the early phase of the pandemic. But as we know, this is an ongoing issue, and many schools, well, now we're in the summer period, but still in spring in Ontario, the schools were still closed, and an issue around access to school-based immunization were still very persistent. So what respondents have mentioned now is that some of them did offer them immunization in their clinic, so about 28%. But most of them actually responded that they would just, defer these vaccines to schools when they would reopen, or leave them to public health clinics when they would be implemented. And a few percentage actually mentioned that they could give these vaccines at a later date when physical distancing measures would be loosened. So this is kind of interesting because with the ongoing school closures in Ontario, there has been kind of a loosening in the providing of school-based immunizations for healthcare providers, and healthcare providers were essentially told, well, if you could give, vaccines that are usually given in school settings, that would be great. So they've been told that, in the past few months, and just to kind of like go into some comments that we have gathered at that time related to this recommendation from the Ontario Ministry of Health. Some of them did find that it was not their responsibility, and that vaccination provided in schools should be public health responsibility, and seem to be kind of less inclined or found that they were not really able to help out with the catch-up strategies for school-based vaccinations. And what they had mentioned at that time is that there were a lot of barriers to accessing these vaccines, and that they were not readily available to them because they would be usually given in school settings. But as I've mentioned, this has changed in the past few months, and now these practices have been quite relaxed by public health, and healthcare providers should be more able to access these vaccines. And some respondents have mentioned more positive comment and mentioned that if they would have access to these vaccines, they would be happy to administer them in their office, and they would have the capacity to do that. So before going into solutions, I'll just acknowledge some of the limitations of such a survey study. Certainly, the results are kind of limited by the response rate, by the fact that this is done with convenient sampling, and that there may be selection bias in that. Respondents who are more aware of the importance of immunization may respond to the survey compared to people who are not. We need to acknowledge that we did not include nurse practitioners, nurses, and pharmacists who can give vaccine in Ontario. And this was a cross-sectional study design, which was done in the early phase of the pandemic. So if we were to repeat such a survey, the results may differ right now and may actually differ in other provinces and other settings. And obviously, this is not a population-based study. So it's a small subset, but it's 20% of the people who have received the survey, so 20% of the pediatricians in Ontario, but it is yet not population-based. So it may not be representative, and it may not be representative of what is truly going on with vaccine coverage in Ontario. So what is happening with vaccine coverage in Ontario? As I mentioned, it's quite challenging to obtain data and precise data of what is going on with the vaccine coverage, and then there is no universal electronic centralized registry to catch all vaccine doses. So there are multiple ways to look at this data. And one way to do that is to look at the electronic medical records of patients, so EMR data from patients to see what vaccines they have received and what vaccines were given by their primary care providers. And that's essentially what we've been doing, as we have partnered with the Utopian Network, which is the University of Toronto Practice-Based Research Network, which is a large network of practices mostly throughout the Greater Toronto area, but that also include practices outside of Toronto in more suburban and rural settings. So in partnership with them, we have conducted a retrospective repeated cross-sectional study to look at what is happening with vaccine coverage of the patients who are enrolled within this network. So we've looked at the vaccine coverage from January 2019 to December 2020. So about nine months following the beginning of the pandemic here in Ontario. Our inclusion criteria was children who were aged 0 to 2 years old to capture vaccines that are given 18 months and lower. Children who were born on or after January 1st, 2017 were included. These patients needed to be registered and rostered to family physicians that are included in the network. And then we've done some validation to ensure that the data was captured adequately and that patients did not fall outside of the network during the study period. Our primary outcomes were the up-to-date immunization coverage. Therefore, it's the proportion of children who have received all valid doses required by specific milestone ages. So if they were up to date at a specific age with the vaccines that are detailed here following the publicly funded Ontario calendar. And then we looked at on-time immunization coverage, which is the proportion of children who have received the vaccines that they should have received at a specific milestone with a 3-day leeway period after the recommended date for vaccine administration. We have also compared 3 periods, so the pre-pandemic period from January 1st, 2019, so a little more than a year, up to March 16, 2020, which is the declaration of emergency here in Ontario. We looked into the first wave of the lockdown of the pandemic in Ontario, so from March 17 to July 31st, and then this kind of recovery period from August 1st to December 31st, 2020, which has included most of the second wave as well. So in total, there was more than 12,000 children who have been enrolled in this study. You can see here some of their characteristics. Once again, most of them in urban settings, so from the Greater Toronto area. A smaller percentage from rural settings was captured though. Here are some other characteristics, so SES characteristics, including neighborhood income quintiles, material deprivation quintiles, and ethnic concentration quintiles. Of note, this is not captured at the patient level, but this is by linking the data with their FSA, so their postal codes. So what we have found is actually aligned with what has been seen in other settings and globally. So we can see here that this is the up-to-date coverage on every vaccine, and we'll go into specific vaccines exactly to see why this percentage seems to be a bit low at baseline. But here we have 71%, around 71% of children who were up to date until the pandemic. And we can see an important decline during the first phase of the pandemic, with a little bit of recovery in that recovery phase. And you can see here the percentages that are listed. So 71% overall in that pre-pandemic period. In the second trimester, there was a 5.7 decline overall, which was statistically significant. And the change was lower from baseline in the recovery period at 4.1%, but certainly not as high as what was seen before the pandemic. We disaggregate these results by age milestone. So this is the on-time immunization coverage and not the up-to-date coverage. So this is for children who have received the required vaccine within a 30-day period following the milestone that they should have received it. We can see that this impact is certainly greater in older children. So children who were 2 months of age did not have much of a change, if no change at all. Similarly, for patients who were 4 months, we start to see a little bit of a decline in patients who are 6 months, and this decline is increasing as children are older. You can see here the exact value for the first pre-pandemic period, with 51.8% of 18 months children who are on time for their vaccines, with a 16% decline during the first phase of the pandemic, which has recovered a little bit in that second period, but is not as high as what it was before the pandemic. If we disaggregate that by vaccine type, so this does not correspond to the on-time immunization coverage, but just the up-to-date coverage for all vaccines in children who are aged 2. So we can see here that children who are aged 2 years old in the pre-pandemic period, about 95% were up to date in their DTaP IPV vaccine. There's been a bit of a decline during the first phase of the pandemic with a bit of a recovery. And this phenomenon is exacerbated for the varicella vaccine, with an important decline in the first phase of the pandemic and a little bit of a recovery following that. And a smaller drop for the MMR vaccine and the meningococcal vaccines, MMR vaccine being given at 12 months old. So you can see here some of these results. The declines were significant for all vaccines, but certainly is higher for the varicella vaccine. And some of the other vaccines have had a smaller decline, but it was statistically significant nonetheless. We have disaggregated some of this data by social demographic characteristics, just to see if there would be an association of this reduction in vaccine coverage by SES characteristics. We can see here that markers of material deprivation, ethnic concentration, and income quintile are certainly associated with a lower coverage. And there seems to be a higher decline in immunization during the pandemic, but this decline has actually been homogeneous throughout all of these groups. And the decline was not statistically different between all of these groups, although the baseline coverage is lower in these groups as what would be expected from the literature. So this is for on-time coverage. This is for up-to-date coverage. We have assessed similar characteristics. So the question at the end of the day, when we see these numbers, and these numbers that seem quite concerning, is really, can or will such a decrease in vaccine coverage lead to changes in the epidemiology of vaccine-preventable diseases in children? And it certainly could, and it has been seen in some other countries. This is the WHO dashboard that has been updated for vaccine-preventable diseases just a few weeks ago. And indeed, in the region of the Americas, obviously including South America, there has been an increase in many vaccine-preventable diseases secondary to the impact of the pandemic on immunization coverage of children. This includes diphtheria, mumps, yellow fever, and measles, which is a big concern because this rise in measles has been seen in other low and middle income countries. Now, we need to keep in mind that increases in vaccine-preventable diseases are dependent on the baseline routine immunization coverage. So certainly in countries or higher income countries, such as Canada, with a higher coverage rate than what is seen in LMIC, the risk of seeing outbreaks of vaccine-preventable diseases remain lower. However, now that physical distancing measures are relaxed or will be relaxed, and that travel restrictions are starting to be relaxed, children here in Canada remain at higher risk of such vaccine-preventable diseases, and that remains a big concern. So what's happening essentially with vaccine-preventable diseases and infectious diseases here in Canada? So this is from a study that we have published a few weeks ago. We haven't looked yet at vaccine-preventable diseases, but we have looked at data from the Public Health Agency of Canada for influenza and RSV. And what we have seen is that with lockdowns and with physical distancing measures, there hasn't been cases of influenza and RSV during the winter period, with an important diminution of the transmission of SARS-CoV-2. There may be other factors that explain the fact that there hasn't been any transmission of influenza and RSV, but as of March of this year, and even as of now, there hasn't been transmission of these viruses since these physical distancing measures have not yet been relaxed, and obviously because of the usual seasonality of these viruses. However, there seems to be a bit of a change in the seasonality of viruses and of infectious diseases. This is what has been seen in the US. This is data that goes until about 2 weeks ago. These are the numbers for RSV, and there has seemed to be an important rise in RSV now that SARS-CoV-2 physical distancing measures have been relaxed, which is quite unusual compared to what is usually seen with the usual seasonality of RSV. And this is true for some vaccine-preventable diseases as well, including rotavirus. So as you can see here, there's been a raise in the percent positive rate of rotavirus as well. But it seems to be a bit early to tell if there's any difference in other vaccine-preventable diseases. But this certainly highlights that as physical distancing measures are relaxed, it is important for children to really be up to date in their vaccine coverage, obviously beyond vaccines for COVID-19. So just to go quite briefly into some of the possible solutions to this issue that we have identified. So from our survey, we found many suggestions and many possible solutions that respondents have acknowledged. So this is from the open-ended question. So you can see here that the first and the solution that has been identified by most respondents was assistance in providing PPE to practices by government and public health instances. So this ties into access to PPE being an important barrier to immunization services, as respondents have acknowledged. Some participants have mentioned some practice level reorganization in order to be able to get their vaccine. So to reorganize their patient flow to make sure that healthy and asymptomatic children who are coming in for their routine childhood immunization or assessment are not seen with children who could have SARS-CoV-2 or could have another infection. So there's been a lot of organizing of their patient flow. They have implemented patient screenings as well, and you know, some other kind of practice level solutions, such as masking of the patients and parents, as what one would expect from infection prevention and control measures that should be implemented in healthcare settings. An important solution that I want to talk about is the education targeting parents. So many healthcare providers tying into the important barrier that has been identified in that parents are concerned to coming into healthcare settings. So practitioners have mentioned that they did some phone calls, that they put on pamphlets, that they send out emails, for example, to their rostered patients to tell them that it was safe to coming into their practice, and that it is important for them to seek routine healthcare and to seek vaccines and to come in for their appointment. And this messaging is still very important, as we saw there is ongoing impact of the pandemic, well, as of December 2020. So certainly there's still some parental concerns around this issue, and anecdotally, this is also what we still see as pediatricians when we talk to parents. And this has actually been acknowledged in some studies who have looked into what were parental perspectives, including some qualitative study to ask parents if they were concerned to get routine childhood services, including immunizations. Lastly, there were some kind of higher level suggestions by practitioners, including dedicated centers or practices for vaccination. So to have either a clinic or to have, similar to what we see with COVID-19, to have mass immunization clinics, for example, which could be mandated with catch-up schedules for children to ensure that they would be up to date in their vaccines. And similarly, a few respondents have acknowledged this as an important barrier, but that an important solution could be a centralized immunization record, which ties into the challenges of gathering data to vaccine coverage to organize these catch-up strategies. So other methods that we've been doing into establishing solutions and implementing solutions. A few weeks ago, the Center for Vaccine-Preventable Diseases at the London School of Public Health, University of Toronto, has organized a roundtable with multiple stakeholders, including pediatric infectious diseases, pediatrician, family physician, public health, schools, in discussing the issues around immunizations for school-aged children and the ongoing closures of schools here in Ontario, and trying to find possible solution for catch-up strategies to fill in the gap from a decrease in vaccine coverage that has been identified. And through this roundtable, multiple solutions have been recommended, and the report should be made available in the upcoming weeks. So I just wanted to kind of glance into some of these recommendations, but just very high level recommendation, mostly for healthcare providers, and some of them kind of tie in with what was identified in the survey results that I've just shown. So healthcare providers are important partners in the identification of unvaccinated students, given the lack of a systematic way to do that at an upstream level. So it is important for a physician to try to identify these students and to give out some messaging that patients who they follow and who are not up to date in their vaccine should book an appointment at their office and catch up on these vaccines. They should, this ties into another issue, but they should scale up the supply from public health and administration of school-age vaccines to meet the high demand for catch-up programming that will be seen in the upcoming year. And once again, communication strategies are really important to increase awareness about missed vaccines in parents and the general public. As such, healthcare providers should implement government and public health communications when they talk to parents and when they distribute such communications. For public health and for governments, essentially, this ties into things that we have been discussing, but essentially to leverage existing platform that could identify immunization gaps. So here in Ontario, especially for the COVID-19, the rollout of COVID-19 vaccines, there has been a platform that has been implemented, which is CANVax Ontario, and all doses of COVID vaccines need to be recorded into this platform. So to have such a system and to leverage such a system and use it for other vaccines would be extremely useful in identifying what are the immunity gaps and to plan appropriate catch-up strategies. So to improve access, as we've been mentioning, some of these vaccines are mostly available through public health or school-based programs, but it is important that the distribution of these vaccines are scaled up to other settings and to increase the possibility of accessing these vaccines by children. Public health could also think about, as we have been discussing, opening mass immunization clinics, such as been done with COVID-19, to catch up for all missed doses of school-based immunizations. And this really speaks to the fact that a multi-pronged approach is important, and that multiple stakeholders need to be invested in the catch-up strategies, including healthcare providers, public health, and government. And as such, these strategies should be well communicated to the public, who should be aware of all the possibilities to access vaccine to catch up for any vaccines that they have missed secondary to the pandemic. So to conclude, there has been substantial impact of the COVID-19 on immunization worldwide, as we have seen, and there certainly has been an impact in Ontario, which is aligned with global trends. We have seen that this decrease in immunization coverage could indeed lead to an increase in vaccine-preventable diseases, especially in the face of relaxing of physical distancing measures and travel restrictions. And as such, it is important that catch-up strategies with a multi-pronged approach involving primary care physicians, involving public health and governments should be implemented in order to catch up for any immunity gaps that has been seen secondary to the pandemic. I would just like to acknowledge some of my colleagues and mentors, Dr. Sean Morris, who's a pediatric infectious disease specialist at SecKids, Dr. Sharon Burry, who's a pediatrician and the president of the Pediatricians Alliance of Ontario, was incremental in doing our survey study and distributing her study to pediatricians throughout the province. Dr. Karen Tu, who's the PI, and Dr. Catherine G, who led this study from the Utopian Network, and lastly, Dr. Shaza Fadel and Dr. Jeff Kwon from the Center for Vaccine-Preventable Diseases. And with that, I'm happy to take any questions that you may have.
Thank you so much, Pierre-Philippe, for your presentation. At this time, we are entering the Q&A period. So please submit your questions in the Q&A box. It looks like we have 2 questions that appeared so far. So the first one's from Sarah. It appears that the varicella immunization rates decreased throughout the pandemic. Has Ontario considered giving the combination product MMRV to eliminate the need for additional visits? This is a practice in Saskatchewan.
This is such a good question. As you may have seen with my name and my slight accent, I'm actually from Quebec, and this has also been the practice in Quebec. So to give the combined vaccines of the MMR with the varicella vaccine. So certainly it's been a difference for me to acknowledge that the varicella vaccine was given at another visit in Ontario, but maybe I could pull out one of my graphs. But essentially what has been seen in our study is that this has been done by practitioners, actually. This has been done at a practice level by healthcare providers' decision, in that some of them just regrouped the 15-month-old visit with the 18-month-old visit. And they gave the varicella vaccine at the same time as the MMR, as within the same visit, but with 2 shots in order to kind of eliminate this supplemental visit that could lead to, more parental concern around coming to healthcare for just one vaccine. So some practitioners have seen that, and it also explains why the on-time immunization assessment for varicella is not as good as the other vaccines, although it's not as up to date, but it still doesn't fall within that 30 days period that it should be given in Ontario at that 15-month-old age range. So certainly this has been an information that we have relayed to public health stakeholders. Now, certainly the decision as to which vaccine is given within each province is really high level, and it's a factor that comes from multiple stakeholders, including, what is the availability of vaccines, what is the contracts with pharmaceuticals for the availability of such vaccines, and for now it's kind of left as is. But certainly public health stakeholders are aware that physicians have kind of tried to regroup these 2 vaccines, and I would kind of put some thought into regrouping these 2 vaccines together in the future.
Great. So we have another question. With COVID-19 vaccines for children under 12 in the horizon, and considering the recommendations for simultaneous administration of COVID-19 vaccines with other vaccines, how can we ensure that the rollout of COVID-19 vaccines does not further disrupt the uptake of routine immunizations?
Yeah, also another great question. So this was discussed in the roundtable as supplemental barriers to catch-up strategies. and was certainly seen by some public health units in the planification of their catch-up strategies. So some public health units were actually planning to do their catch-up strategies during the summer, but they had to postpone it completely because of this recommendation, because of their COVID-19 rollout. Not only that, but also for the allocation of resources by public health. It's more challenging to plan both, the mass immunization of these school-age children with COVID and with other vaccines. But we hope that in the future, potentially, all vaccines could be given at the same time, which would certainly be easier for logistical purposes. And we hope that it's going to change in the near future, and that the Centers for Disease Control and Prevention in the US have changed their recommendation. And now they don't recommend this period of 14 days to 28 days after vaccination, and other vaccines can be given at the same time as COVID-19 vaccines in the US. And NASI has provided a bit of an open frame, and that what they mention is that for children who are completely unable to access a vaccine outside of this period, it may be reasonable to give it. So there is a bit of a leeway in that. But certainly, the recommendations from NASI in general remain that it should not be given within this period. But we hope that with by the time that the schools restart in August, September, it's possible that this recommendation by NASI will have changed.
Yeah, that's definitely a good point about the co-administration, especially since it's going to be happening for school-based immunization and just not even related, but kind of related, but with flu as well.
Yep. Absolutely.
So, yeah.
You're absolutely right.
Yeah.
But I mean, here, once again, each province are doing something a bit different for their influenza campaign. But here in Ontario, it's kind of universal recommendation that everybody should receive the influenza vaccine. So certainly for the flu season, it will pose an important challenge with the administration of the COVID-19 vaccines, and being able to offer these two vaccines at the same time would be logistically easier.
Absolutely. All right. So it looks like at the moment we don't have any questions in the question box, but I just have a question for you, Pierre-Philippe. I noticed you were mentioning some solutions for physicians in order to uptake with vaccine. I had a question about the education campaigns to parents, and I know this is probably very soon, but with Ontario reopening, have you heard any at least anecdotal experiences of any successes with educating the parents and calling them to remind them to get their vaccines? Have you heard of any of that so far in this early time?
Yeah, so I mean, certainly it could warrant some sort of organized approach, in developing a specific intervention and evaluating what could be the outcomes from the implementation of such interventions. However, this hasn't really been done, but anecdotally, that's exactly what we're hearing, from family physicians and pediatricians, either through their survey or just kind of like mouth to ear words. That's what we are hearing from providers, and that they have been successful in relaying these messages. Mostly practices who have access to EMR and are able to send out emails to their patients and parents. So emails. Reminders seems to be what is the most successful. Once again, this is very anecdotal, and in order for me to give like an evidence-based answer, we would need to look into kind of objective studies into that question.
Absolutely. Well, thank you for answering that very anecdotal question that I asked. We have a couple other questions coming in now. One from Jacqueline. School boards seem to be getting involved in educating parents on COVID-19 vaccines. Could we do the same for school-based routine immunizations?
Oh, I'm sorry, can you repeat the question?
Oh, sorry, yes. So the question was, school boards seem to be getting involved in educating parents on COVID-19 vaccines. Could we do the same for school-based routine immunizations?
Yeah, so yeah, sorry. So I didn't hear the first part of the question, but certainly yes. this will be part of the framework of recommendations from the CDPD. Certainly school and school boards have been identified as important stakeholders to relay these messages, that in order to keep schools safe, kids need to be vaccinated. But not only that, but it's also a provincial regulation here in Ontario, and there are laws through the Pupil Immunization School Act, that they should be immunized. So certainly schools need to be involved in that, and I think the best way to do that is to reinforce the messaging that has been going out around COVID, that COVID-19 vaccines are important in order to keep communities safe, including in schools. And it's the same for other vaccines, and that schools, if schools want to, keep their environment safe for children and for teachers and for school staff, it's important that they, participate in the efforts to get their students vaccinated. So certainly it's really important to have a good dialogue with school boards and stakeholders in school settings.
Absolutely. All right, and we have another question. Are you planning to publish the results of the survey as a report or as a scientific publication in a journal?
Yeah, so the survey has been published in the journal Vaccine. So it's available. Maybe we could have the link available somewhere following this webinar. But it is available online as a scientific article. And then our study that we've done with the partnership with Utopian will also be published, I hope, in the near future. So our results will hopefully be available online in the upcoming weeks and months. I hope earlier than later. But certainly these results have been relayed to public health stakeholders.
Okay, great. We can actually put that link in our post-webinar email to all registrants, and we'll also have it uploaded on CANVax so that you folks can also see it as well. So that's great. So another question has come in. In Ontario, what is the system for practices requesting school-age vaccines from public health? Are there plans to streamline/simplify the process?
Yes, we hope so. So actually, there's no one-fits-all answer to that question, in that it really depends on the public health unit. So these vaccines are the responsibility of public health units who are held to wasted standards, and they decide how they distribute them to providers within their public health units. So really, it's depending on the public health unit. For now, it's still kind of on a patient level. So, like practitioners who have identified this patient is missing on their school immunization and would like to have the vaccine. Therefore, they have to order it from the public health unit. So that's kind of like the overall process. Now, some public health units have looked into a more kind of generalized approach, and that could be like sending these vaccines in bulk to a practice, and for the practice to organize a day in which they would catch up on vaccines for their patients. But certainly there are still kind of room for improvement to have a more streamlined process and ensure that healthcare providers could have access to these vaccines multiple at a time, and not kind of be burdened with the task of doing that for each individualized patient.
Right. Awesome. Well, it looks like we have no more questions, and it's about 1:59 Eastern time. So I think that brings us to the end of the webinar. Thank you all for attending and asking the questions. Thank you so much, Pierre-Philippe, for your wonderful presentation. Just a quick reminder to everyone to fill out the post-webinar evaluation survey upon closing your browser. Thank you again, and have a wonderful afternoon and stay safe.
Thank you very much.
Thanks. Bye, everyone.